Hello and welcome to this discussion today on evolving trends in hormone receptor positive early stage breast cancer diagnostics with a focus on extended endocrine therapy, ovarian function suppression, and beyond. I am Rena Callahan. I am a medical oncologist at the University of California, Los Angeles. And I am joined
by VK Gadi. I'm a physician scientist and medical oncologist at the University of Illinois Cancer Center and also a breast cancer medical oncologist.
So welcome today. I think it's important to remember we've been here for several days at this conference hearing a lot about metastatic disease, but it's important to remember that most of our patients have early stage disease. Right? And of those, most of them have estrogen receptor positive breast cancer. So this is a very large group of women in the United States and across the world for whom we need to be aware of our obligation to provide better treatments. So you'll see here the NCCN clinical practice guidelines in oncology with a focus on gene expression assays in making decisions about adjuvant systemic therapy. Over the course of our patients' treatment, we're making several decisions at different time points. Initially, a lot of it focuses on whether adjuvant chemotherapy would be beneficial. And to guide this decision, the most recommended genomic assay is the Oncotype, the 21 gene recurrence score. But later on in a patient's treatment, we're making additional decisions about adjuvant endocrine therapy. We're getting to the 4 or 5 year time point and trying to decide whether extending for another 5 years will be helpful to our patient in prevention of metastatic disease. And here you'll see that this is where Breast Cancer Index fits in with an expanded NCCN list for genomic assays. It is the only one that is predictive of benefit of extended endocrine therapy. And so we're going to delve into that. So these predictive diagnostics will help us avoid both over and under treatment. So this is a figure that I show a lot of my patients. I pull it up on the monitor to drive a few points home. One, so this is from the Early Breast Cancer Trialists Collaborative Group publication in 2005 of tens of thousands of women who are treated with either tamoxifen for up to 5 years or placebo. And so one point that I try to make here is that the decisions that you make early on about adjuvant endocrine therapy have an impact on outcomes much later in the course of your disease. So whether you take tamoxifen for 5 years or not initially has a marked impact on your risk of recurrence at year 15. Another point that this shows, which is sobering, is that there's no magical 5 year time point where one can say, okay, you're cured, have a big party, that there remains this risk of distant metastases over the subsequent 10, even 20 years. And so we need to address that by modifying therapies and coming up with therapies that can address this issue of late recurrence. So if some is good, is more better? Well, this was looked at in several large trials of over 25,000 women shown in these 6 trials. So we have tamoxifen followed by AI in MA17 and ABCSG6A. We have tamoxifen followed by tamoxifen in Atlas and Adam. And then extension of AI in MA17R and NSABP-B42. And what we see here is an absolute benefit of about 3 to 5% for extending endocrine therapy another 5 years. Great, right? But what that's also saying is that 95% of our patients don't benefit from extending therapy, right? Only 1 in 20 is going to benefit, and the remainder, the 19, do not. So how do we make these decisions to help figure out, who's really going to benefit. Well, many of us are providers, physicians, NPs, and so we gain clinical experience, and it's natural for us to want to try to look at what's right in front of us to help make our decisions. And so some of these things, come right off the pathology report: tumor size, grade, quantitative ER/PR, Ki-67, nodal status, the age of a patient, and even we're tempted to use other genomic assays because it's nice to just use one thing. Unfortunately, however, those factors, those clinical pathologic factors, can help us make an assessment on prognosis, but what they don't do is reliably predict the benefit of extending endocrine therapy. So we need a test that is able to do that. And so here we have breast cancer index, which can predict that benefit of extending therapy. So what is breast cancer index? Well, here it is. So it's actually two tests. There is a prognostic portion of the test and a predictive portion of the test. So the prognostic portion uses an algorithmic combination of 11 genes that are involved in cell proliferation and estrogen signaling, and assesses an individual's risk of late distant recurrence. So simply put, it's a percentage of recurrence between years 5 and 10. But the other portion I think is even more interesting, which is the predictive portion. And here we have a separate algorithm of a biomarker called H/I that are genes involved in estrogen signaling. So HOXB13 and IL-17BR. So a ratio that tells us a high ratio predicts a yes, a patient is likely to benefit from extended endocrine therapy, and a low ratio gives us a no, that our patient is not likely to benefit. As a result of validation study after validation study, breast cancer index has been recognized by our big national guidelines. So NCCN, which I showed you a bit earlier, let's get into the verbiage, which states in a secondary analysis of MA17 trans-Adam and ideal trials, patients with hormone receptor positive T1 to T3 node negative or node positive disease who had BCI H/I high demonstrated significant improvements in disease-free survival when adjuvant endocrine therapy was extended compared to the control arm. In contrast, it states, BCI H/I low patients derive no benefit from extended adjuvant therapy. In the ASCO guidelines, it states, BCI may be offered to patients with 0 to 3 positive nodes who've received 5 years of endocrine therapy without evidence of recurrence to guide decisions about extended endocrine therapy. That clinicians may offer the BCI test to guide decisions with either tamoxifen and AI or tamoxifen followed by AI. It then goes one step further to state that other genomic assays, such as Oncotype DX, EndoPredict, Prosigna, as well as Ki-67 and IHC4, that they are identified as having insufficient evidence to predict benefit from extended endocrine therapy. So let's take a quick look at these validation studies. So these studies included tissue blocks of over 4,500 patients across 5 trials. And you see here there is some heterogeneity in what endocrine therapy was used, AI, tamoxifen, or both. There was both node negative and node positive disease. But what is consistent is that when you apply BCI and you get a high, a yes, that there's a 2/3 risk reduction in the development of distant metastases for patients who extend endocrine therapy out to 10 years. And conversely, if there is a no, that there is no benefit, even if these patients are node positive. So we need additional strategies that will help us avoid over and under treatment.
Thank you, Dr. Callahan. So we wanted to present some cases that are illustrative of how this might roll out in the real world. So here we'll discuss one of these patients. This is a woman who's age 54, probably postmenopausal at the time of diagnosis, node status N1, so worrisome, 2 out of 10 nodes are positive here. Tumor size is 1.3 centimeters, grade 2, really robust ER expression, but a loss of PR expression, always worrisome, HER2 negative. And she has some symptomology, severe joint pain, mood swings, et cetera. And she gets the BCI test ordered around this 5.5-year time frame, probably suggesting she had 6 months of chemotherapy, gets endocrine therapy for 5 years, et cetera. So this is a pretty typical patient in that regard. And here we have a patient who has a no result. H/I score is low, so that's a no result. And that predicts that there is no benefit from extending endocrine therapy. And so when you get the report for this patient, you get the dichotomous result on the top, and on the report on the bottom, you get the actual number or the rate of possibility of recurrence beyond those first 5 years. And despite having started off the day with a relatively sort of yucky scenario, node positive, youngish, ugly looking PR status, et cetera, she's got a low risk of late distant recurrence, 1.9%. So this is a patient that I think many of us might knee-jerk say, hey, you're in a bad situation, we've got to extend you. Yet this is a woman that's not going to benefit from that, and in essence is only going to be left with the harms of extending endocrine therapy. I'm sure I've certainly had these patients. Have you seen patients like this in your practice?
Yeah, definitely. Very recently, in fact. And, it takes me back to when she was initially diagnosed, the entire focus was on whether or not she really needed chemotherapy or not. So we sent an oncotype, and thankfully it was low, hooray, even with 2 positive nodes, she doesn't need chemo. But then over the next, 5 years, she's on endocrine therapy, which really changed her life. She gained 20 pounds, aching all the time, felt old, so really didn't want to be on it, but she would have continued on it. But we sent BCI and got a result that was very similar to this, and she was just, thrilled, and we both felt confident about taking her off.
Thank you. So I'm going to just walk through a couple more data slides. So I think, like I said, one thing that we always worry about with our node positive patients is that they are at high risk, not just at early recurrence, but potentially at late recurrence. And here we have patients that I think we look at and go, gosh, you're high risk. Yet when you look at them at a genomic level and look at this expression level of these 2 genes, a quarter of those patients are essentially low risk and very unlikely to benefit from extending of endocrine therapy, similar to the patient we just discussed. And what does this play out like in one of those studies? So this is a little graphic from the IDEAL trial. So just to walk you through this, in the IDEAL trial, patients were randomized after 5 years of endocrine therapy to extend for 2.5 years versus 10 years of extension, a full 10 years, 5 years of extension. This is a high-risk patient cohort entering this study. There was no randomization to no years of extension. Many of these patients needed chemotherapy. The investigators at the time felt that it was not appropriate to randomize to no years, so it's 2.5 versus 5 years of extension. And what you're looking at here is kind of a yucky flavor of tumor, node positive, large tumors, T2 or greater. Yet when you look at the subgroup of patients from that trial that had low scores on the BCI biomarker, the HRI biomarker, there is no difference between the partly extending and the full extending arms, underscoring what this data looks like in one of the trials when you have that result. So just to also just drill down a little bit deeper on this node positive space, when you look at these trials that we were just talking about, MA17, TransAtom, IDEAL, there's a pretty robust representation of patients who have node positive disease. And yet here too, again, if you have the high HRI biomarker, we see a very consistent relative risk reduction of about 2/3, anywhere from 65% to 58% to 71%. And on the flip side, on the converse, if you have a low score, no HRI result, no benefit for any of those groups statistically. So really all we can do for those patients by exposing them to these drugs for longer is only give them the harms of these therapies. So for the node positive aspect, I think that's one of the parts where people still feel uncomfortable about relying on a biomarker. Our gut instinct is to rely on the clinical pathologic factors, but our gut instincts can be wrong, especially in the face of a molecular feature. So now you see within the NCCN guidelines, us getting more confidence, again, highlighting in the node negative, but also in the node positive patients, this test can be useful, both in the NCCN, but also in the ESCO guidelines. And then just the node positive patients as just what does that look like in one of these trials? So this is from the TransAtom study. This is specifically looking at the node positive patient. Just to remind everybody, TransAtom was an extension study of 5 more years of tamoxifen versus not. And in that trial, we had a positive result for the entire population, roughly about 4%. So put another way, 1 in 25 patients is going to benefit. And in this subset of the node positive patients, that was really reflective from this validation cohort of being the same in the other. And then when we look at the breakout by the H/I biomarker, in the low H/I biomarker cohort, if anything, it was going in the wrong direction, right? You can see it going down below. And then there was a complete enrichment for the patients who are going to benefit from this extension in the in the HRI high biomarker group with the YES score. And when you look at the hazard ratio here, relative risk reduction of, again, 2/3, 67%, and a number that actually tilts in the wrong direction for the low patient group.
So what do you do when somebody, just going back to, what about someone who has a high risk and a no benefit, right? That's a pretty difficult situation. And, there's 4 different outcomes when you have the prognostic yes percentage and the predictive yes or no. So how do you handle those patients?
Yeah, that's a hard conversation. It's a little bit of a gut punch to have to look at a patient and say, gosh, you still have residual risk. But one thing I think we all try to do as medical oncologists who are thoughtfully thinking about not just the allopathic interventions, but some of those other things that we can do like diet and exercise and the wellness behaviors. We know from well-done, controlled, randomized studies that those interventions also lead to good outcomes from our patients, and yet those are not available to the patients on these trials. So I really drill down into the things that the patient can control. It's not just a pill always. This is a nice thing to know where you stand, and it really reinforces those other behaviors that actually have a huge impact. So I turn this sort of ugly news into like a positive spin.
Right, you can do this.
You can do this,
yes,
yeah, exactly.
Right, exactly. Well said. All right, another case. Here we go. So this is our patient who is 55 years of age. She is a 1.5 centimeters, so pretty small, node negative, grade 2 tumor, strongly estrogen and progesterone positive, HER2 negative. Her oncotype score is low. So we order BCI 5 years after diagnosis, and here is the result. Get a yes, 8%, with a 2/3 risk reduction of extending endocrine therapy another 5 years. Dr. Gadi, tell me about your experience with patients who've had this type of report.
Yeah, I've certainly had this experience where patients, despite having what looks like a low-risk tumor, are still at residual risk. That basically they have dormant micrometastatic disease that just hasn't presented, and this ongoing suppression in those microenvironments of estrogen signaling actually has impact. And the way I walk this through with the patient is, you have your absolute risk of what that might be, and there's this relative 2/3 risk reduction. Well, that's lost on patients, right? I say, I took your number, which was a 1 in 12 chance of recurrence, and I've now turned it into a 1 in 3, 1 in 4 chance of recurrence, right? Oh, sorry, I did it the other way around. 1 in 40 chance of recurrence. So I think that's kind of how I talk to it, and I think that resonates a little bit differently than kind of the statistics of it.
Right, absolutely. And I'm a big fan of this report, which has changed over time to actually show the yes 8% and then what you can expect. Earlier this week, there was a patient advocate who gave a beautiful presentation and pointed out that different patients learn in different ways. And so, if you're a visual learner, having something like this right in front of you, I think is a very helpful tool in our discussions of some pretty complicated information. So, we've talked about how we shouldn't make assumptions based on clinical pathologic factors. So here, taking patients with clinically low risk features, we're risking making assumptions that lead to undertreatment. So in this analysis of about 500 patients, there were patients pulled out that had clinically low risk disease, so T1 and 0. BCI was able to identify about a quarter of them as likely to benefit from extended endocrine therapy and at higher risk of late distant recurrence, so a worse prognostic result than one might think. So it helps pick out the wolf in sheep's clothing so that you don't undertreat your patient and can save her from metastatic disease that would be life-limiting, presumably. So going back to the IDEAL trial that Dr. Gadi had presented, here we're pulling out patients who have low clinical risk features with a high BCI. And so you can see here, these patients have T1 disease or grade 1 disease. And if there is a BCI high, extending endocrine therapy from 7.5 to 5 years gives a delta of 12%. You know, that to me is pretty dramatic. So talking about treatment length a little bit more, sometimes we talk about 5 versus 10 years, but in the IDEAL trial, what was being compared was 7.5 to 10 years. And then some of you may be familiar with the SALSA ABCSG 16 data of 7 to 10 years, you know, and it's, some of us may make the assumption that, okay, why don't we just give 7 years? Isn't that enough? It's a little bit more than 5, but not as much as 10. But we can see here from this validation trial with BCI that if they're BCI high, that 2.5 years does make a difference with a 58% relative risk reduction in the development of distant mets. All right, so oncotype, we spoke a little bit about how you can't use one genomic classifier outside of what it is supposed to be used for. And so there was a head-to-head analysis of oncotype and BCI using the trans-ATAC cohort, which showed that when you're looking at prognosis, specifically late recurrences, that oncotype is unable to differentiate patients. You'll see at the bottom, the confidence intervals cross 1, but BCI is able to do so. So this has led to the ASCO guidelines, which call out inappropriate use of other genomic assays to make decisions about extending endocrine therapy. So in this analysis, BCI was able to reclassify or classify patients who on oncotype had a low risk of recurrence at a high risk of late recurrence in about a quarter of patients. So oncotype recurrence score low, presumably they don't need chemo, but a quarter of them may be at a high risk of late distant recurrence. So we really need to focus on those patients and what are the strategies that we can use to prevent that. That makes sense. So we've spoken about this a lot from the physician's point of view, right? Why can't we just make our decisions however we do and then tell our patients what to do? Well, we're not the ones, taking the medication every day and suffering some of the side effects that really have an impact on patients' lives. So there are major compliance issues with extended endocrine therapy where about 40% of patients are non-compliant with extended endocrine therapy. In this analysis, there are a variety of reasons why. Sometimes it's not just side effects. It can be side effects. Sometimes a patient, it just falls off. They're tired of taking anything. You don't know whether it's working. So it just falls off. So in this analysis that was presented last year at San Antonio, it was an analysis to look at, does BCI actually change decision-making for patients? And what was shown is that 82% of patients who were told that extending endocrine therapy would be beneficial to them in preventing distant metastases, that they were more likely to be compliant based upon the BCI results. So that's patients. What about physicians? We're a pretty tough group. But in this analysis, BCI was able to change minds of about 40% of physicians. So it is useful and practical in that regard. So just to review, who is BCI useful for? When is BCI indicated? Well, for pre, peri, postmenopausal women, lymph node negative and lymph node positive, up to 3 positive nodes, T1 to T3 tumor size, grade 1 to 3 tumor grade, HER2 positive or HER2 negative. We didn't focus that much on that, but there is data with HER2 positive breast cancer, ER and or PR positive, chemotherapy treated or untreated, ductal and lobular histology. There was a lobular paper using BCI, and the patient, of course, has to be non-relapsed. So just to review the long treatment course for our patients, we use evolving diagnostics to make decisions at different time points. In the beginning, chemotherapy, many of us use Oncotype or a similar genomic assay, and then primary endocrine therapy for 5 years. And then in making decisions about extending endocrine therapy for another 5 years, Breast Cancer Index is a validated, guideline recognized tool to help us make these decisions and avoid over and under treatment. There are more questions than this. Who needs chemo? Who needs an extra 5 years of endocrine therapy? I can think of a lot of questions that we have. Some, does everybody need endocrine therapy? What endocrine therapy is needed for any individual patient? Those are just some things I think about. What are some things that you think about, Dr. Gadi?
Being a bit of a futurist in this space, we have some concrete things that we're now doing differently that were not available to these patients. Namely things like adjuvant CDK4/6 inhibitors. We have one of those approved, likely to have another one. What's the outcome of those patients in terms of long, late, distant recurrences, and can that be impacted? In the absence of data, I still believe that these data are relevant to those patients, and so it doesn't immediately change my behavior, but boy, would I want answers to those questions. Yeah. And then the other, I think, big intervention that could be coming down the road is, of course, adjuvant oral SERDs. If we are now taking fulvestrant-like drugs and incorporating them in the adjuvant setting, are we going to be lowering the risk of late distant recurrences? We don't know the answer to that question. Right. Just thinking through the problem, though, these are dormant cells, micrometastatic niches, and it's not entirely certain to me that those cells are following the same game plan and rule book that the more early recurrent kind of cancers are following. So interesting scientific questions. We obviously need data, but those are the burning ones, at least in my mind.
Right. Yeah. Absolutely.
So there's one additional question, and that's what we're going to get to next. So I think we've clearly seen the value of this test in this patient that's been through 5 years of endocrine therapy and is facing this important decision. We have something that, in my view, is a standard of care decision-making tool and can be incorporated for those patients. However, this is an interesting molecular diagnostic that's really interrogating that micrometastatic niche in terms of its endocrine sensitivity and its inflammatory nature. And that's what that ratio really is telling us. And so the question then naturally that can be asked is, what's that going to play out like in an earlier stage setting? And of course, you want to study this in the context of something that's potentially very high risk. So that's young women who are at risk for early recurrences. And we have now data showing us in that setting that ovarian function suppression, in addition to endocrine therapy, whether that's tamoxifen or aromatase inhibitors such as exemestane, can be helpful. So what is this biomarker going to inform us about that in that setting? So this is, of course, presented last year at this meeting. Lots of attention to this by Ruth O'Regan. And I just wanted to go through that data, having reflected on it for about a year now, about what that kind of looks like. Now, I will warn you that this data is hypothesis generating right now. We do need to validate it a bit more. So if this is a drug talk, we would talk about on-label, off-label. So everything we talked to about up to this point was, quote, on-label, about how we actually use it. And now this is that future state of what might this look like as more data accrues. So we'll talk about the SOFT trial first, kind of set up and remind everybody of what that was. And then we'll go through the biomarker analysis through the translational cohort. So SOFT was a very large trial. By itself had greater than 3,000 patients. These are early breast cancer patients with hormone receptor positive disease, and they were premenopausal after chemotherapy or premenopausal and never received chemotherapy, and were then randomized in this interesting way, 1:1:1, where the standard of care at the time for those women was to get tamoxifen, and then the randomization was to add ovarian function suppression with tamoxifen or ovarian function suppression with exemestane. Here going forward, I'm just gonna say OFS. And looking at the stratification of those patients, about half received chemotherapy and half did not. And the bottom line from that, and we have now lots of follow-up, at 12 years of median follow-up, there's about a 3% difference for distant recurrence. That was not the primary endpoint of the study, but looking at the thing that we as medical oncologists are really worried about, late distant recurrences, that number was 3% better with exemestane and ovarian OFS versus TAM alone, which is a control arm, highly statistically significant. And overall, when you compare the exemestane and OFS versus TAM versus OFS, 1.3% versus 1.4%. So both did improve, and they do look modest, right? But they're impactful for this patient group. So patients who may currently be considered for ovarian function suppression, this is a bit of a clinical decision right now. There are things in the study that really did come out, young age, high grade, lymph nodes, and that's what's on the NCCN guidelines. In addition, there have been additional post hoc analyses performed. So there's something called a STEP analysis that was published a few years ago in early 2020 in the pandemic. I don't know if everybody got to read that paper, but in that paper, they looked at clinical factors that might predict. So, and they created a scoring system of sorts. So for example, a patient that was very young, 35, had nodes positive, might have received chemotherapy, those patients are very likely to benefit from ovarian function suppression, OFS, plus exemestane, as an example. But wouldn't it be nice if we had a genomic marker that can inform us on that rather than the clinical? In many other contexts, the genomic markers have really outperformed the clinical markers, including in the extended adjuvant setting. So this is the sort of unmet need that we could do this. So that was, of course, performed in SOFT. And in that biomarker cohort, there was 1,717 patients. 30 didn't have enough DNA, and at the end of the day, the final cohort was 1,687 patients where this could be looked at. The primary outcome for the biomarker cohort was to look at whether or not the H/I biomarker predicted benefit from escalation with exemestane and OFS versus TAM alone. A secondary endpoint looking at that same question with tamoxifen instead of exemestane. And then additional study endpoints, or notes to note, is that the endpoint was breast cancer-free interval, and BCFI is a composite endpoint that includes invasive, local, regional, distant, contralateral events, and looks for that in the predictive analysis. So first of all, when you look at the first panel on the left, that's the overall cohort from the biomarker-enriched cohort. It honestly looks just like the main paper. Not a big difference. The three arms play out the same way, showing that there's benefit from the escalation all the way to exemestane plus OFS compared to TAM alone, with the other arm in between. However, when we broke out the cases based on the biomarker, an interesting signal emerges. So in the patients who had an H/I high score, remember, that means endocrine-sensitive cancers. Just giving endocrine therapy alone with tamoxifen was equivalent to escalating with exemestane and ovarian function suppression, so no difference there. However, in the cancers that we now, but from this biomarker, understand to be less endocrine-sensitive in those microenvironments, that's where the impact of escalating made a difference. So when you look at this, exemestane plus ovarian function suppression had almost a 12% difference between the tamoxifen alone arm, and in between that was the tamoxifen and OFS versus the TAM arm. So some study conclusions based on this: the BCI translational cohort was representative of the SOFT cohort. It wasn't cherry-picked, it was nicely represented. And then in the recent evaluation within that cohort, we kind of get a hint at who might be benefiting from OFS, not just based on clinical factors, but now on a molecular feature. And that low group consistently derived benefit in a meaningful way from OFS, while BCI H/I group did not. And so this is kind of an interesting, where are we heading with this? So just putting that into practice, or can we put that into practice? I think it's still early. We want to basically repeat this experiment in the same way that BCI was repeated for many, many trials in the extended adjuvant setting. We want to feel confident that this is a biomarker that can help in this way. I know personally that this company that has developed this assay is actually trying to do that right now. But we want to make sure we validate that properly before putting it into play. But I do think that the biomarker is still telling us a very consistent signal about what's happening in that microenvironment. So this is just exciting news, I think, that's on its way.
Yeah, thank you for that. So here we are now At the end, you've listened to a lot of information, and I know many of you have captured it. So you can take it home with you, but it will, I think, be available on YouTube as well for those of you that didn't have your phones ready to take the photos. So it's just some key takeaways from the last 45 minutes. Breast Cancer Index continues to demonstrate strong performance as a predictive biomarker in ER-positive early-stage breast cancer, which is the lion's share of all breast cancer. That data from the SOFT trial showed promising results for BCI as the first and only biomarker to predict OFS benefit, and that additional clinical validation is ongoing prior to using the test for OFS decision-making. Breast Cancer Index remains the only validated and guideline-recognized test to predict which women with hormone receptor-positive early-stage breast cancer are likely to benefit from extending endocrine therapy.
Well, thanks everyone.
All right, thank you for your attention.